to order. So welcome to meeting number 36 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the COVID-19 pandemic, specifically today examining Canada's national emergency response landscape. So I'd like to welcome the witnesses. We have from the Privy Council Office, we have Ms. Christine Tremblay, Deputy Clerk, Ms. Tao Pham, Deputy Secretary to the Cabinet Operations, Ms. Jody Van Dien, Counsel to the Clerk of the Privy Council and Assistant Deputy Minister, Privy Council Office, Legal Services Sector. With the Department of Public Safety and Emergency, and Emergency Preparedness, we have Mr. Rob Stewart, Deputy Minister. From the Ministry of Health of Israel, hopefully later we will have Dr. Asher Shalman joining us, Director of the International Relations Division. And we have, with the Regional Municipality of York, we have Mr. Bruce McGregor, Chief Administrative Officer. So I will invite the witnesses to make their opening statements. And just to note that I have these colored cards. Yellow means your time is almost up. Hopefully it will be, if I don't lose track, it will be a minute before your time is up. And red means your time is up. And if you see that, you don't have to stop instantly, but try and wrap up if you can. So thank you. So we will start with Privy Council Office. I believe it's Ms. Christine Tremblay. Please go ahead. 6 minutes, please. Ms. Tremblay, you seem to be muted. You didn't check the switch on your headset. See if it's muted.
Ça va mieux?
Ça va très mieux. I'll start your time again. So please go ahead now. 6 minutes, please.
Merci, Monsieur le Président, et bonjour, Messieurs et Mesdames.
Thank you, Mr. Chair, and hello to the members of the committee. Thank you for the opportunity to appear before this committee to discuss the federal response to COVID-19 in the context of emergency management. My name is Christine Tremblay, and I am the Deputy Clerk of the Privy Council and Associate Secretary to the Cabinet and the Deputy Minister for Intergovernmental Affairs. I am joined today by my colleagues, Tao Pham, Deputy Secretary to the Cabinet for Operations, Jody Van Dien, Assistant Deputy Minister of PCO Legal Services, and Rob Stewart, Deputy Minister of Public Safety and Emergency Preparedness. The Government of Canada's efforts responding to the pandemic run the gamut from federal investments in public health, such as testing and contact tracing, or the purchase of personal protective equipment, providing direct financial support to individual Canadians and businesses, ensuring adequate and reliable supply of therapeutics and medical supplies across the country, maintaining effective border measures to minimize the importation and spread of the virus and its variants, and purchasing and distributing vaccines to provinces and territories. The federal government has also worked collaboratively with provinces, territories, and Indigenous communities to manage the pandemic. Public health measures are largely within provincial and territorial jurisdiction, but the federal government sought to ensure they had the tools and resources to exercise this jurisdiction. Federal funding to support Canadian workers and businesses provided the space for provinces and territories to enact public health measures in their jurisdictions tailored to their specific circumstances. Through the Safe Restart Agreement, the federal government provided over $19 billion to support provinces and territories with increasing testing and contact tracing, healthcare system capacity, and more. In addition, the government announced a further $5 billion in March for pandemic support for provinces and territories in recognition of the ongoing pressures COVID is putting on the healthcare systems. The federal government also provides PPE, medical equipment, and surge capacity support to provinces and territories. This includes the provision of testing and contact tracing supports and mobile health units. The federal government has responded to 70 requests for assistance. My colleague Rob Stewart is responsible for their coordination. This includes deployment of the Canadian Armed Forces to long-term care facilities, support for vaccinations in remote First Nations communities, and most recently, the deployment of nurses and medical assistance teams to Ontario hospitals. Additionally, the federal government is providing federal healthcare staff and equipment to the front lines. It has provided additional supplies of needed drugs through reallocation from other provinces and territories and developed laboratory testing capacity within our federal labs. Through our partnership with the Canadian Red Cross, support has been provided to long-term care facilities in several provinces, and additional nurses and physicians have been recently deployed to assist with the current situation in Toronto. PCO has played a central role supporting the Prime Minister and the Cabinet throughout the COVID-19 pandemic. This includes supporting the Cabinet Committee on the Federal Response to the Coronavirus Disease, which has a mandate to ensure whole-of-government leadership, coordination, and preparedness for the response to and recovery from COVID-19. We have also played a central convening and coordination function, working with departments and agencies horizontally across government on a wide array of COVID-related priorities, as well as communications through our COVID Communications Hub. My colleague, Tao Pham, is at the heart of this work. Our responsibilities for intergovernmental affairs has also meant that we have been leading engagement with the provinces and territories, including supporting, in the last 15 months, 30 First Ministers' meetings, which have focused primarily on the response to the pandemic. The last meeting was 10 days ago, and all of the premiers of Canada were there. I understand the committee is interested in discussing the legislative tools that exist at the federal level to respond to emergencies, such as the current public health crisis in which the country finds itself. Parliament has granted the government authority to deal with emergency situations in several acts of Parliament, and some of these authorities have already been employed in dealing with the pandemic. An example of this is the Quarantine Act, which has been used to implement restrictions at the international border, including mandatory testing and quarantine requirements for travelers. The Emergencies Act also exists as one possible tool for dealing with emergencies of a national nature. There are 4 types of emergencies that can be declared under the Act: public welfare emergency, public order emergency, international emergency, and war emergency. This would be a public welfare emergency in this case. The law includes a specific definition of a national emergency as urgent, critical, and temporary in endangering the lives, health, and safety of Canadians that exceeds the capacity of the provinces to deal with. Importantly, additionally, the federal government is obligated to consult with provinces and territories prior to invoking the Act. As such, a cabinet decision to invoke a national emergency under the Act is a measure of last resort. The Prime Minister consulted with the premiers of the provinces and territories last spring regarding the potential need for invoking the Emergencies Act. The consensus among premiers.
Merci, Monsieur le Président.
Thank you, Mr. Chair.
On your point of order, go ahead.
I was just wanting to make sure we had time for questions because the
Okay.
witness was going over time.
Yep, thank you. And thank you, Ms. Tremblay. We'll go now to Mr. Stewart, Deputy Minister. I believe you have a statement as well. 6 minutes, please.
I will save you time by only making a few short remarks. Obviously, emergency management has been a very large feature of the landscape over the last year. We go back in time, we had a snowstorm in Newfoundland, and we had disruptions to critical rail infrastructure before the pandemic struck. We have been busy. I'm here today to talk to you about the structure of the federal government's response to emergencies and how we coordinate with the provinces, the tools we've used, and the situations we've responded to. I'm at your disposal. Thank you.
Thank you, Mr. Stewart. Well, we'll go now to Dr. Shalman, Director of International Relations Division, Ministry of Health of Israel. Dr. Shalman, welcome. You didn't have a chance to test your sound, so maybe if you could say a few words to make sure the interpreters can hear you properly, and then we will carry on with your statement.
Okay, good morning, Ottawa. Can you hear me well?
Thank you. Could you say a little bit more so that the interpreters can have a chance to...
Good morning. My name is Dr. Asher Salmon. I'm the head of International Ministry of Health Israel, and I'm delighted to be here with you. Is it fine?
Thank you. We'll get the thumbs up, hopefully, from the interpreters. Mr. Clerk, are we good?
Put your mic, hold it near, close to your mouth, please. Yeah.
Can you hear me better now?
That would be better this way. So we'll try this way. Okay, Mr. Chair.
Okay. Thank you, Mr. Clerk. So Dr. Asher, please go ahead. I invite you to make a statement of 6 minutes. When your 6 minutes is up, I'll show you the red card. Please do try to wrap up. Thank you. So go ahead, please. 6 minutes.
Okay. Thank you. Thank you for inviting me. It's a pleasure being here. So I was asked to speak about Israel campaign, vaccination campaign, which is quite a successful one. We did start early. Actually, December 19, the Prime Minister and the Ministry of Health were publicly vaccinated. And from the morning of the 20th, we have started to vaccinate widely all over the country. Now, we did decide to go on a simple scheme, meaning that from the first day, we had vaccinated everybody which was 60 and above, and medical personnel and first responders all over the country with no subgrouping. And then on a weekly basis, we had dropped the age by 5 years till at the point of week 8, the campaign was fully open for the whole population above the age of 16. We are now discussing when to start vaccinating teenagers. We did not authorize yet the vaccine for 12 to 16, but we are working on it. And I do believe that until the end of next week or the week after, that will be authorized in Israel and we'll be ready to start. As you may know, Israel decided to take a single approach. We are using only Pfizer-BioNTech vaccines. We do have a clear deal with Pfizer regarding shipment dates and the exact terms of how the whole project is working. So we were appealing for them as we are running it as a national IT-driven, I would say, operation where every case is fully registered to the national registry, but at the same time registered by his HMO into his personal electronic medical record. As I have mentioned, the whole project was a paperless project, so you did have to pre-register for your appointment. Although if you did not register and you would queue, you had a good chance to be vaccinated anyhow. In the peak of this vaccination program, we did vaccinate more than 200,000 people a day. And remind you, we are 9.25 million residents here in the state of Israel. We did vaccinate everybody which is here, citizens, temporary residents, diplomats, foreign workers, even asylum seekers and illegal immigrants who are fully vaccinated from the first day. And we did as well vaccinated our diplomatic corps around the world. We hope to have some bilateral agreement with countries. We did understand that it would not work in the pace that we were looking for, so we did basically vaccinate everybody by ourselves. Regarding compliance, it was a good compliance. I think the psychology of supply and demand in the beginning was a major issue for the public. So people were queuing and people were trying to get it sooner rather than later. Of course, it had changed as this campaign had moved on. And now we are putting a lot of emphasis into the last pack of the adult population, which are hesitant or against. We do understand that devoted anti-vax would never be convinced. So we are putting our effort into hesitant people and as well into some communities with lower numbers, like the Bedouins in the Negev and some ultra-Orthodox communities, which we are pushing them ahead to be vaccinated. Now, it's not obligatory. You have the right not to be vaccinated, although there are some crucial working places that are expecting everybody which are giving crucial service to the public, like health sector, to be vaccinated. We do not have a legal frame to force it, but it's kind of an understanding that that is what we do expect from our employees. We do issue what is known to be a vaccination certificate, which is fully electronic. It's a barcode, and you get it a week after the second dose. That is, in this point, I may add that we decided to stick to the manufacturer protocol and to vaccinate everybody for the second dose on day 21. The Green Pass is another document which you are entitled to receive if you are recovered or be fully vaccinated. And that's allowed you into what is known to be Green Pass zones in the country, mostly restaurants, bar, gyms used to ask it, but now by law, gyms are open for everybody, including public swimming pools, large cultural events, concerts, all of them could operate under a Green Pass registry, meaning that they are allowed to have much larger gathering of people than what is known to be the purple tag, which is a standard COVID-19 restriction for general places like supermarkets, pharmacies, hospitals, etc. Just to sum up numbers, more than 90% of our medical personnel is vaccinated. More than 90% of 60s and above are vaccinated. And if we look at the adult population of Israel, near 80% of the population or was vaccinated at least with a single dose or had recovered. Around 9% of our population was found positive by PCR test to carry COVID-19 sometime in any point during the last year. So that's where we are. And I'll be very happy to answer questions. I guess there are a few. Thank you.
Thank you, Doctor. Before we carry on to our next statement, Ms. Tremblay, I've advised that your mic may not be properly selected, so if you could check that. And while you're doing that, of course, we will carry on with Mr. Bruce McGregor, Chief Administrative Officer from Regional Municipality of York. Mr. McGregor, please go ahead, please, 6 minutes.
Thank you, Mr. Chair. Well, as a former soccer coach, I'm a little sensitive to yellow and red cards, so I hope you won't be using those. I'm the CAO of York Region. There are 9 cities and towns that extend north of the city of Toronto to Lake Simcoe and serve as home to over 1.2 million Canadians. We're an upper tier municipality and provide 14 core services to all of our communities, ranging from courts through policing, transit, water and wastewater, to name a few. We also deliver public health services as one of 34 public health units in Ontario under the direction of Ontario's Chief Medical Officer of Health, as prescribed under the Health Protection and Promotion Act. This is a model that differs from practices in other provinces. Our public health responsibilities are also delivered through a community and health services department in an integrated model that also includes paramedics, social services, long-term care, and housing, all of which have a focus on the social determinants of health. The perspective I'll provide you today is as the CAO of a large Greater Toronto Area municipality, where our regional council also serves as the Board of Health. York Region has a comprehensive emergency management and preparedness program that is tested annually as required by legislation. Through our emergency management program, threats are assessed annually using a hazard identification and risk assessment. Since SARS in 2003 and H1N1 in 2013, pandemic risks have increased in priority and focus. Formalized business continuity planning is also part of our emergency preparedness and is centered on maintaining critical services. On January 23rd, 2020, our Medical Officer of Health, Dr. Kareem Kurji, activated the Public Health Emergency Operations Center to respond to the COVID-19 pandemic threat 1 month before York Region recorded its first case. On March 17th, 2020, York Region activated the Regional Emergency Operations Center, and by March 23rd, York Regional Chair Wayne Emerson had declared York Region's first ever state of emergency under the Emergency Management and Civil Protection Act. Prior to and throughout the pandemic response, York Region and our 9 local cities and towns have worked together very closely. Our local municipalities have been an added source of assistance during York Region's mass immunization efforts. With public health embedded in our organization, we're able to redeploy approximately 1,000 staff from within our organization to support the public health response. Additional critical internal supports were immediately redirected to enable staff working remotely. We redirected procurement to rapidly acquire personal protective equipment, human resources to quickly hire required specialized staff for long-term care and public health, and communications to ensure updates were available through multiple communication channels. Business continuity plans documenting essential services and functions with assigned priorities helped to quickly identify services that could be suspended or reduced to shift staff resources to support the COVID-19 response while ensuring critical core services continued uninterrupted during the pandemic. York Region has in place robust and well-tested incident management systems that will serve emergency response efforts well into the future. We've strengthened relationships with our local municipalities, community partners, and elected officials, and forged new relations with experts from various fields, such as the Red Cross, St. John's Ambulance, local physicians, hospitals, and pharmacies, all of which will support our future decision-making. What we've learned through forced digital transformation will not be lost, with efficiencies and opportunities incorporated into our new normal moving forward. Provincial and federal funding programs have enabled many Canadians to refrain from going into workplaces while enabling businesses to receive support during shutdowns. Without this financial support, the pandemic outcomes would have been much worse with respect to community and workplace transmission. While most of York Region's population has access to consistent and reliable broadband technologies to support remote working, there are many rural parts of our communities that experience the ongoing challenges that persist in rural areas throughout Ontario and Canada. As we optimistically shift from the response phase of the pandemic and into recovery, individuals and businesses will continue to require provincial and federal assistance and supports, hopefully with a stronger commitment and component of funding critical public infrastructure. Through the COVID-19 experience, York Region's state of preparedness is higher than ever before, and as we look ahead to the potential of recurring infectious diseases, it will become critical to remember this experience and guard against complacency. We're hopeful for progress in 3 specific areas, working together with our provincial and federal partners. First, encouraging domestic production and supply of personal protective equipment and vaccines. Secondly, investing in broadband to support all Canadians in working and schooling from home. And third, ensuring consistent and clear communication between all levels of government to educate and inform the population we serve as a vital component of any emergency response. So thank you, Mr. Chair, for your time this morning and for the opportunity to share York Region perspectives shaped by our organizational emergency management and public health model and experience.
Thank you, Ms. McGregor, and thank you to all the witnesses for your statements. We will start our questioning right now. We will start with Ms. Rumpel-Garner, please, 6 minutes.
Thank you. I'll start by issuing hearty congratulations to the government of Israel on their vaccine rollout program. I'll then direct my questions to Ms. Tremblay. Have any of the vaccine procurement contracts been sent to the law clerk per the October 26 motion in the House of Commons?
Bonjour, Monsieur le Président. Est-ce que vous m'entendez bien?
Do you hear me correctly now? Can you hear me well? Yes. In the motion, the Privy Council, in collaboration with all of the departments, are reviewing documents. To date, over 5 batches of documents were shared, including thousands of pages.
Have the vaccine contracts been provided to the law clerk per the motion?
Pas à ce jour.
Not yet. Work is still underway with the pharmaceutical companies.
Has the government directed you to not send these documents to the law clerk?
Ces documents,
These documents belong to the pharmaceutical companies. We are actively working with these companies.
So you have not sent the contracts to the law clerk?
nous travaillons avec les
We are working with the pharmaceutical companies to share with the clerk the appropriate documents.
Did the PCO provide direction or approval to any department or minister that ATIP operations should be shut down during the pandemic?
Monsieur le Président,
Mr. Chair, no. All of the units for access to information are working in government.
At the start of the pandemic, did the PCO provide direction or approval to any department or minister that ATIP operations should be shut down?
je répète ma réponse.
I will repeat my answer, Mr. Chair. All of the access to information units are working.
Thank you. Will a national proof of vaccination system be available to Canadians within the next 4 months?
Monsieur le Président,
Mr. Chair, if I may, I could ask my colleague, Tao Pham, who is responsible for the COVID operations, to answer that question.
Good morning, Mr. Chair, MPs. Really pleased to be here. Thank you so much for the invitation. So maybe I'll try to respond to Ms.
I don't have time. We only have a few minutes. Will a proof of vaccination system be available to Canadians within the next 4 months?
Well, as you know, the federal government is working very closely with provinces and territories in terms of rolling out the vaccination. Of course, the provinces and territories are the key interlocutor and responsible for rolling out the vaccination, and therefore we will continue to work very closely.
I asked about a national proof of vaccination program. Is any plans for a national proof of vaccination system underway?
Well, we are working closely with all of the provinces and territories because, as you know, each province will have the specific systems, but we're
Is it fair to say no?
working.
Is it fair to say no, that there won't be a national system for proof of vaccination then?
Well, provinces and territories, as you know, are rolling out the vaccination program right now, and we are continuing to work with them.
So there are no plans right now for a national proof of vaccination program. It will be up to the provinces.
We are working with the provinces and territories. Of course, as you know, the federal government has responsibility for international travel. So a number of departments are also looking at international standards with the WHO.
So where there'll be a national system that is managed by the federal government?
Well, maybe, Mr. Chair, if I can just finish my answer here. So I guess the federal government has responsibility for international border. So we are working with international partners such as the ICAO and WHO to look at those international standards. And of course, we are continuing to work with the provinces and territories in terms of rolling out.
Thank you for the non-answer. To Mr. Stewart, was any advice given to the federal government that quarantine and enforcement mechanisms should be fully set up at our borders and airports prior to directing 1 million Canadians to come home at the start of the pandemic?
If I understand your question well, you're asking whether or not we were enforcing the borders as we are today.
No, I was asking whether or not you gave advice to the government to set up quarantine and enforcement mechanisms at the border prior to directing 1 million Canadians to come home at the start of the pandemic.
The advice to the government was provided by the Public Health Agency of Canada, to be clear.
Are you aware if the Public Health Agency of Canada directed the government to set up quarantine enforcement prior to directing Canadians to come home at the start of the pandemic?
To be clear, as things unfolded over the course of January and February of last year, we were working to bring Canadians home before we declared a pandemic and before quarantine measures were imposed.
Thank you. back to Ms. Tremblay. When did Canada begin negotiations with CanSino?
Can you repeat the question, please?
When did Canada begin negotiations with CanSino for the development of a vaccine?
Je suis pas en mesure de répondre.
I'm not able to answer that question.
Ms. Tremblay, I'll ask the same question to you that I did to Mr. Stewart. Did the government receive any advice to put in place quarantine measures prior to directing Canadians to come home at the start of the pandemic?
À l'intérieur des travaux.
During normal work at the COVID-19 committee, border issues are discussed among ministers.
Was any advice provided to the government to put in place a quarantine mechanism prior to directing Canadians to come home at the start of the pandemic?
Comme l'ensemble des dossiers.
As with all files, options are always offered to the ministers for decision making.
So a quarantine mechanism was given to the government at the start of the pandemic.
Monsieur le Président.
Mr. Chair, I mentioned that options were proposed to the ministers for decision making.
Was a quarantine measure included in those options?
Thank you, Ms. Rempel-Garner. Thank you. We'll go now to Mr. Van Bynen. Mr. Van Bynen, please go ahead, 6 minutes.
Thank you, Mr. Chair, and to our witnesses with us here today. I want to especially thank Bruce McGregor from the Regional Municipality of York for taking time off his busy schedule to bring a regional perspective into our discussions. I also want to thank him and his team for their work during these difficult times. And it's always been great to work with you, Bruce, and I appreciate the updates of the current situation that your team has been sending out regularly. Bruce, in your opening statement, you mentioned that throughout the pandemic, the region has worked closely with the municipalities. And I'm wondering if you could expand on this collaboration and share with us a bit more about the roles played by the province, the region, and local municipalities, including the differences between each role.
Well, thank you, Mr. Chair. It's certainly a privilege to bring the local experience to this federal table. We are creatures as municipalities of the provinces and consequently are guided by legislation. In Ontario, that legislation includes a bit of a deeper dive into what are normally services provided by the provinces elsewhere in Canada. So we deliver public health, we deliver housing, social services in partnership with the province of Ontario. With funding, of course, as well from provincial sources. All of that can't possibly fit into a property tax bill. But we do also provide services municipally, and we share those municipal services with our local municipalities that are a collection of towns and cities. Cities like Markham and Vaughan with 400,000 population each and growing, and small rural towns, relatively smaller rural areas with populations of 30 to 40,000. But we, at the regional level, deliver the large consistent services across that area, including the provincial services. We deliver policing, we deliver paramedic services, we deliver water and wastewater, transit, transportation. Local municipalities deliver library services, fire, and recreational services as well. So with respect to the pandemic, of course, our emergency services are connected quite tightly. That's paramedics and police at the regional level, fire at the local level, also with their provincial oversight bodies, of course, engaged as well. Our medical officer of health takes direction from the provincial chief medical officer of health. And of course, there's information flowing from federal sources in the health sector as well. I think, Mr. Chair, that's a quick answer to that question. I hope I haven't left anything out.
A few weeks ago, the region's Facebook page shared a table titled COVID-19 Phase 1 Vaccine Rollout Roles and Responsibilities. I was quick to share that on my page because I think it's unclear to many Canadians, and unfortunately even with colleagues in the House, the role that's played by each level of government as more and more COVID vaccines become available. And I just asked you about the role of the provinces, the municipalities, and the region in this pandemic, so I won't ask you to repeat yourself, but I am wondering if you could share why the region saw it was important to share this information, and where did you find the information about the role that each level of government plays in this pandemic?
So, Mr. Chair, there's tremendous anxiety amongst Canadians generally with respect to vaccination. For the most part, people wanting to get vaccinated and wanting to get two rounds as recommended by the manufacturer. So people are taking information from all kinds of sources. And we found that it was important to manage those expectations relative to the supply of vaccines. We're not alone in the world. Vaccine shortages are even more chronic in some jurisdictions in the world, and we had to make it clear to our residents what we are able to control and what is controlled outside of our jurisdiction. So we had clearly set out the role of the Government of Canada, the role of the Province of Ontario, the role of our municipalities, and frankly, the role as well of the community, because the community has to be responsive. And we've had some wonderful responses. 2 of our mass vaccination clinics are run by community practitioners. So it's a great sign of everybody coming together to provide not only managing expectations, to provide the best possible service and getting vaccinations into arms.
Mm-hmm. So from a regional perspective, Bruce, what are some of the lessons learned and some of the gaps that were found in the responses to this pandemic? And what are some of the recommendations that you would provide us?
Well, I summarized at the conclusion of my comments 3 areas where we feel there could be better preparedness for pandemics. In this last generation of municipal employees who are currently employed in our workforce, we've had 3. This is our 3rd pandemic of sorts, SARS, H1N1, and now this one, which is much more significant than others. So we always look to lessons learned as we did from those prior experiences, and are certainly the provision of personal protective equipment is a very important one. And if there was local manufacturing, that would be helpful, as we discovered. Vaccine availability, development, and availability is important as well. I think what we've certainly learned is it takes all 3 levels of government to chip in and to make this work. The funding coming from the senior levels of government has been absolutely critical to keep our communities in a position where they can recover.
Great. Thank you. Thank you, Mr. Chair.
Thank you, Mr. Van Buynen. Nous allons maintenant.
We now go to Mr. Thériault. Mr. Thériault, go ahead, please. 6 minutes. Thank you, Mr. Chair. Mr. Stewart, public safety seems to have difficulty in properly managing the borders. We heard of false tests. Could you give us an idea of the scope of that phenomenon? What have you done to address that issue?
Oui, avec plaisir.
Yes, with pleasure. In fact, there are very few fraudulent tests at the border. I'm sorry, I don't have the numbers before me. I can send them to the committee after the meeting. But we are studying this closely in partnership with public health when it comes to travelers and CBSA. And I can tell you it's a very small percentage of the total number of travelers who have a fraudulent test. Is that just the number that you were able to catch? Or is that really the whole scope of the issue? What are you doing exactly to detect those tests? Once again, I couldn't tell you exactly how CBSA determines that it's a fraudulent test, but we have a documentation standard and an examination standard. So documents given to CBSA are examined. My colleague could probably elaborate. What is your relationship with public health? It seems there's a communication issue, because when there are variants that come in and restrictions are announced, it's too late. So how is it that we have so many variants here when the government claims that it has some of the strictest measures on the planet? Do you communicate? Is there a good weighing of the risks and the proactive measures at the border? I could provide what I know, and that is that the incidence of the disease is very minimal, about 1% of travelers. And with the Public Health Agency of Canada, we have a framework that is very strict with quarantining, tests before and 2 times after arrival. And again, we have numbers that indicate that the incidence of disease is very low, very, very low. You'll agree with me that if it's that strict and effective, there would be far fewer cases of variants cases linked to variants in the country. That being said, within that same vein of better control at the borders, what does public safety think of vaccine passports? Of course, we will need a vaccine passport so that Canadians can travel abroad and so that we can understand the status of people coming into Canada. And to respond to a question asked earlier, we are in dialogue with the provinces and territories. So we have a way of understanding the status of vaccination for an individual. When you say to properly understand this vaccination status of an individual, what do you mean? So a type of certification. Okay. So what you expect is that communication between the provinces, Quebec, and the government would be to provide you with what? The information that you need for proof of vaccination? Yes. It's in the public interest and in the interest of all Canadians to have the ability to travel. And I believe there's a good level of collaboration so that we have a way of identifying the vaccination status electronically. So you've recommended better control at the border and a vaccine passport, is that correct? Sorry, I didn't. So you'll be recommending a vaccine passport for better control at the border? Yes, absolutely. Thank you. Thank you, Mr. Thériault.
We'll go now to Mr. Davies. Mr. Davies, please go ahead, 6 minutes.
Thank you, Mr. Chair. First off, I think on behalf of all of my colleagues, I'd like to express our best wishes to Mr. Shugart for a speedy recovery and for his good health. Madam Tremblay, I'm going to read to you a little bit, an excerpt from what parliamentarians were told in 1987 when they were reviewing Canada's emergency legislation landscape from a federal point of view. It said the federal government has primary and ultimate responsibility to provide for the safety and security of Canadians during national emergencies. Its constitutional jurisdiction over such national emergencies stems from the powers of Parliament to legislate for the peace, order, and good government of Canada and the emergency doctrine which has evolved from it. That doctrine invests the Parliament of Canada during times of national crisis with temporary plenary jurisdiction to legislate on all matters.
including those normally reserved exclusively to the provinces. It operates, as Mr. Justice Betts of the Supreme Court of Canada stated in the anti-inflation reference, as a, quote, partial and temporary alteration of the division of powers between Parliament and the provincial legislatures, end quote, which gives to the Parliament of Canada in times of national crisis, quote, concurrent and paramount jurisdiction over matters which would normally fall within exclusive provincial jurisdiction. He also observed, quote, the power of Parliament to make laws in a great crisis knows no limits other than those which are dictated by the nature of the crisis. Is that your understanding, Madame Tremblay, of the constitutional authority of the federal government in a time of national emergency?
Merci, Monsieur.
Thank you, Mr. Chair. Thank you to the member for the question. I think it was agreed among premiers and discussed that yes, this is a national pandemic, and the federal government wanted to prepare itself for every option, so it did consider using the Emergencies Act, but it had to fulfill the three.
I'm not there yet. I'm just asking about the general constitutional authority. Is what I read to you, do you accept that as an accurate description of the federal government's constitutional authority?
Monsieur le Président, si
Mr. Chair, if we're talking about constitutional authorities, I'd like to refer to my colleague, Jody Van Dien, please.
That's a fair reflection of the federal government's legislative authority under peace, order, and good government in an emergency context. And the Emergencies Act was a piece of legislation passed relying upon the peace, order, and good government emergency branch power.
Okay,
and
I'll direct my questions, and thank you, Ms. Dean. I appreciate, or Ms. Van Dien. To you then, it goes on, what parliamentarians were also told was, where the scale of the disaster is such that it affects more than one province, or where it occurs on territory within the federal domain, the federal government will have primary, if not exclusive, responsibility to provide for public safety. So my question to you is, the scale of the disaster has obviously affected more than one province. I think we all can acknowledge that. But it seems that the federal government has taken the opposite view, that the provinces have primary responsibility to act, with the federal government playing a supportive role if asked. Why is that?
The Emergencies Act embodies the federal, provincial, territorial collaboration and working together, and in fact requires consultation with the provinces and territories, and specifically requires that invoking the Emergencies Act for a national emergency only occurs when other federal, provincial, or territorial legislative measures are not sufficient. In addition, in Section 8.3, sub 3 of the statute, the Emergencies Act, it says that when a declaration of emergency were to have been made, following such a declaration, it is of course anticipated that the provinces and territories would continue to act within their legislative spheres, and that the federal government's action should not unduly impair or intrude upon those actions. And I would say that the Supreme Court, since 1987, has very much spoken of cooperative federalism as a key constitutional concept. And I would say that the Emergencies Act, as passed by Parliament, reflects cooperative federalism and federal, provincial, territorial collaboration.
So I want to give you a quote from Dr. Hardcastle, who spoke to this committee last week. She said, "It's surprising to me that in arguably the largest emergency this country has seen since World War II, that we haven't seen the federal government turn to the exceptional powers granted under the Emergencies Act or to pass COVID-specific legislation grounded in the POG power. If the Emergencies Act was not used here, I'm not sure when it would ever be used." My question is given that Canada has now experienced 3 waves of the pandemic, the Canadian Armed Forces have had to be called in 3 times to provinces, Alberta has the worst record in North America, and there are severe, serious outbreaks in Ontario and Manitoba, why hasn't the federal government used any of its emergency powers to date? I guess the supplementary is it your view that Ontario and Alberta are managing this pandemic well? I don't know who wants to field that, Madame Tremblay.
Merci beaucoup pour votre question.
Thank you very much for your question. I think my colleague, Jody Van Deen, talked about cooperative federalism. And the general sense is that the premiers are working together, the provinces are using all of their capacities, and the federal government are using all of their levers, and that together they're facing the pandemic. So that's really the spirit of collaboration. And all levels of government are engaged during this pandemic. And we heard a regional representative today who also expressed that dynamic, that collaboration between all levels of government. And the Emergencies Act mentions that it would be used only if the situation can't be managed otherwise, and that the provinces are not able to face the situation on their own without support.
Thank you, Mr. Davies. So committee, that wraps up our time for this panel. We're going to have to suspend and go to the next panel.
Chair, Mr. Chair, I wonder, we do have a few minutes, and we did start awfully late, and we have the clerk of the acting clerk of the Privy Council here. I would respectfully suggest we have one more round of, say, 1 minute each, because we didn't get a full hour.
Fair enough. That will put pressure on our next panel because I think we'll be shoehorned there as well. But if that's what the committee wants to do, by all means, we'll do 1 minute slots, one slot per party, and we'll go to the Conservatives to start with. I'm not sure who that will be. Will that be Ms. Rempel-Garner?
Mr. Maguire.
I'll go ahead,
Mr.
Chair.
Maguire, please go ahead. 1 minute.
Yeah, to Deputy Minister Stewart, have you provided the government with any advice using rapid tests or for all persons included essential workers at our land borders?
Yes, sir. There is an active dialogue going on. It's not me personally who would provide that advice, but we are working closely with the Public Health Agency and our critical infrastructure unit to
and just along
see
that.
the deploy. Yes.
Along that same line, have you given any advice or recommendations to require any form of pre-departure for domestic air travelers?
That would be in the domain of Transport Canada, but I can tell you that no such advice has been provided. That would be the issue of testing on a domestic level would be a responsibility of the provinces.
And I want to thank Dr. Shalom for his from Israel for his excellent testimony. He pretty well answered all the questions that I had, Doctor. So thank you for being with us. And I think it's remarkable that you could start on December the 19th and have everybody over 16 years old vaccinated by the time 8 weeks are up. So obviously you didn't have any interruptions in vaccine procurement. Is that the case?
Witness may answer.
Yes, it was well planned, and in that sense, it had worked well. Actually, shipments were on time. I think I could recall only one shipment which was late 2 days. Otherwise, things had worked
2 days.
By the unbelievable, you would say. So, at no point we were in shortage because from the beginning we kept the second dose for everybody. So we had some, flexibility in using these extra doses.
Sounds like you had good contracts. Okay. Thanks.
Thank you, Mr. McGuire. We go now to Mr. Kellaway. Mr. Kellaway, go ahead, please. 1 minute.
Sure. Thanks, Chair. My questions for Dr. Stewart. You're closely involved in how the federal government has been supporting the provinces and territories, especially when it relates to emergency requests for supports. So just two very quick questions. Can you tell the committee about the kinds of supports the federal government has provided to the provinces and territories? But the second one is what the process is now, Mr. Stewart, for a province or territory to request more and additional supports?
The Department of Public Safety has coordinated, under its Emergency Management Act responsibilities, has coordinated over 70 responses to requests for assistance from either the provinces and territories or from Indigenous groups. We've provided assistance via the Canadian Red Cross, the Army, and coordinated with public health the delivery of drugs and human health workers, in particular of late, into Ontario. We stand by with an inventory of services and help for provinces, and if they wish to access it, they only have to ask.
Thank you. Mr. Chair, that's good for me. Thank you.
Sorry, I was all muted. So thank you, Mr. Kellaway. We'll go now to, nous allons maintenant Monsieur Thériault.
We now go to Mr. Thériault. Go ahead, please. 1 minute. Ms. Tremblay, it's been over a year that we've been in this pandemic. Some organizations have shared with us that there are some lessons that they've learned. What would be 2 or 3 lessons that you've learned from this pandemic? What you wouldn't do or what you would do differently or do better going forward? Thank you, Mr. Thériault, for your question. If I may, Mr. Chair, I'll go ahead. I think the first lesson is capacity to work quickly together during a situation like the pandemic or any other emergency, and an ability to improve coordination, perhaps, between all levels of government, and maybe also improving the speed of response in some cases. My colleague, Mr. Stewart, mentioned 70 requests for assistance, which allowed us to face the pandemic. Perhaps we could also find ways to accelerate those processes, to be quicker on the ground, and to meet the needs of Canadians.
Merci, Monsieur.
Thank you, Mr. Thériault.
We'll go now to Mr. Davies. 1 minute, please.
Thank you. Mr. Stewart, I'll direct this to you. We learned last week that 2 of the 4 airports receiving international travelers in Canada are not enforcing federal quarantine rules. That's in on Quebec and Alberta. What measures is the federal government considering to deal with that situation?
We have a dialogue with the provinces and territories through a federal provincial policing table, where we are actively working with both the governments and their police forces, the police of jurisdiction, to enhance enforcement of the quarantine.
Thank you. Madam Tremblay, on November 27th, the Clerk of the Privy Council, Mr. Shugart, wrote to this committee with respect to the document production order adopted by the House of Commons on October 26, 2020. He wrote that, quote, preliminary estimates suggest that there are millions of pages of relevant documents. However, according to the law clerk, only 8,166 documents have been turned over by the government to date. Can you confirm whether the government is purposefully withholding documents, or explain why it is being so slow to produce documents ordered by the House of Commons to this committee?
Thank you very much for the question. I think it's a good one. And now we have to coordinate the work all across the government to make sure that there is consistency, that we can remove the duplication. And as we work, the documents are more and more complex, but it's really kind of the intent to share the document with the committee. And from the first answer that for a question that I got earlier about kind of the contract with the company, there is 7 contracts, and we're having discussion with the 7 company in order to be able to share with you kind of the contract as much as possible. So this work is in progress.
Thank you, Mr. Davies. Okay, so that really wraps up our time for this panel. I'd like to thank all of the witnesses for sharing your time with us today and for sharing your expertise and your knowledge. And I particularly like to thank Dr. Shalman for joining us all the way from Israel. So thank you all. And with that, we will suspend and bring in the next panel. So thank you. We are suspended. back to order. So welcome everyone. We are resuming meeting number 36 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the COVID-19 pandemic, specifically today examining Canada's national emergency response landscape. So I'd like to welcome the witnesses. We have, as an individual, we have Dr. Isaac Bogach, physician and scientist, Toronto General Hospital and University of Toronto. We will have Dr. Peter Hodez, professor and dean of National School of Tropical Medicine, not tested, sorry. So we're having problems with his headset, I guess. We have from the Ministry of Health of the Slovak Republic, we have Brigadier General Dr. Vladimir Langvarski, Minister of Health of the Slovak Republic. And we have, is it Dr. or Mr. Martin Pavelka?
Yes,
epidemiologist?
Mr.
Mr. Okay.
Mr.
Okay, thank you. Mr. Martin Pavelka, epidemiologist. With that, we will ask the witnesses to present a statement. I will display a yellow card when your time is almost up and a red card when it's up. When you see the red card, do please try to wrap up. So we'll start with Dr. Bogach. Dr. Bogach, please go ahead, 6 minutes.
Thank you so much. And again, thank you for the invitation to chat today. My name is Isaac Bogach. I'm an infectious diseases physician and scientist based out of the Toronto General Hospital, also the University of Toronto. I sit on several provincial and federal COVID-19 committees and task forces. And over the next few minutes, I'd like to focus on a few semi-related issues related to the pandemic response. I think it's important to frame our conversation within the current and the near future Canadian context. Like, we're still embroiled in a pretty large third wave across most of the country. Provinces such as Nova Scotia and Alberta, unfortunately, have higher rates of infection than ever before, but other provinces are slowly turning the corner. No matter what, we're far from where we need to be, but with mass vaccination efforts expanding, I think it's fair to say that we're going to realize some significant benefits of this vaccination, much like other countries that are a few months ahead of us, like the United States, Israel, and the UK. We're just a couple months behind. But with sound public health measures and ongoing vaccinations, we will likely be far better off in the near future than where we are right now. So with that in mind, I think it's important to focus on a couple of current and near-term issues and really start thinking about what our off-ramp looks like. The first one is border measures. Now, we know COVID-19 isn't going anywhere anytime soon. It's going to be around for a while. But at least for the near future, I think it's reasonable to ensure people traveling and Canadians returning to Canada demonstrate either evidence of COVID-19 vaccination, or if people choose not to be vaccinated, that they still must quarantine and show evidence of negative testing. This virus poses a significant public health threat, and we know it disproportionately impacts our low-income and racialized neighborhoods. Border measures like this won't be perfect, but they'll still reduce the importation of virus. Policies like this seem prudent for the near future. Longer-term strategies remain unclear. Related to the border, I think it's also important to discuss vaccine passports. When I say vaccine passports, I'm referring to vaccine passports as requiring evidence of vaccination to cross an international border, okay? So regardless of what our personal views are of the virus, regardless of what our personal views are of vaccination, there's a growing list of countries globally that require proof of vaccination to COVID-19 to enter, and we should be proactive in ensuring that Canadians who choose to be vaccinated will have acceptable documentation of their vaccine status to enable international travel. Another point is essential workers who cross the border. We know there's tens and tens of thousands of people crossing our borders daily. Many are essential workers, like truck drivers bringing in vital goods to Canadians. They should have priority vaccination. So, for example, we know there's a great program on the Manitoba-North Dakota border vaccinating truck drivers, and this program is exemplary, and we should see more of that. A couple of other quick ones. Airports. I mean, if we were going to shut down all non-essential travel to the country, the time to do it was over a year ago. The current measures are clearly not perfect, but they still buffer Canadians from importing a significant number of cases of COVID. When we look at the current and projected pace of vaccination, when we look at the benefits afforded by vaccination, I think it's pretty clear that there's significant questions when we actually raise the utility and costs of further restricting already restricted travel versus the potential gains. We could also create safer travel by ensuring those who enter the country are vaccinated and continue to quarantine as mentioned above. Lastly, just to touch on the Emergency Measures Act or other measures for federal intervention at the provincial level, a lot of this is easy to say, but I imagine it's much more challenging to operationalize. I don't think there's the capacity for the federal government to micromanage healthcare or public health at the provincial or even regional levels. There would have to be very, very clear and pre-specified divisions of labor to make this work effectively. There's plenty of other COVID-19 related topics to discuss. I don't unfortunately have a lot of time, but I'd be happy to address any of these in the question period that follows. Again, thank you for your time and happy to chat.
Thank you, Dr. Bogosh. We will go now to Brigadier General Dr. Vladimir Langvarsky. Sir, if you would go ahead with a statement, up to 6 minutes, please.
Thank you. Dear Mr. Chairman, Vice Chairs, members of the Standing Committee of Health, dear friends in Canada, I would like to extend my cordial greetings from Bratislava to all of you. I'm pleased and honored to have this opportunity to address you. Likewise, allow me to convey my special thanks to the Honorable Michelle Rempel-Garner, a great friend of Slovakia, for the invitation to share the Slovak experience with the nationwide population testing. Current pandemic is an humanitarian crisis which is threatening to leave deep social, economic, and political scares for years to come. It is therefore highly desirable and responsible to adopt corresponding strategies with relieving potential of the pandemic's impacts. Before the vaccine's introduction, the testing itself was the only efficient tool for countering pandemic. In this context, Slovakia opted for the nationwide testing, which has proven to be helpful in revealing the areas mostly hit by the virus, as well as in reducing the incidence rate. This information was crucial for preparing and adjusting the correspondent region-based measures. Overall, I perceive as extremely important to build synergies at international level, including through sharing the best practice examples. Let me thank you once again for the interest in the Slovak experience related to the testing. In this regard, Mr. Pavelka is ready to provide you with further information on this matter. Stay healthy and keep safe. Thank you.
Thank you, Minister. I'd also like to acknowledge the presence of the Ambassador, Vit Koziak. So welcome, thank you. We'll go now to, we don't have Dr. Hotez yet, do we not?
Yes.
Oh, there we go. Okay. So, Doctor, if you could just say a few words for the interpreters to make sure that they can hear you properly, and then I'll ask you to start your statement. So, say a few words for like 10 seconds or so. You're muted.
It's good to see everybody, and appreciate this opportunity.
Maybe a few more.
I hope everything is working out well, and I hope I can be understood to be translated.
Excellent. Thank you. Mr. Clerk, is that sufficient? I'm getting the thumbs up. Okay. Please go ahead, Doctor. 6 minutes, please.
Yes, sure. Well, thank you to the committee for inviting me. Just very briefly, I'm an MD, PhD pediatrician scientist, and I co-lead efforts to develop vaccines for neglected diseases of poverty, in addition to coronavirus infection vaccines and a new COVID-19 vaccine. So for the last 2 decades, we've built an academic research center known as a PDP, a product development partnership. And what we do is we use industry practices to make the pharmaceuticals that industry generally won't produce, because they mostly target diseases of the poor. And our PDP is known as the Texas Children's Center for Vaccine Development at Texas Children's Hospital and Baylor College of Medicine. We've now developed a low-cost recombinant protein vaccine to prevent COVID-19. Some refer to it as a people's vaccine because it could be scaled for production at extremely low cost. We think as low as $1.50 a dose, and requires simple refrigeration. Biological E, one of the big vaccine producers, has now started to scale up production to more than 1 billion doses, and the Indian Regulatory Authority has now given us the green light to advance it to phase 3 clinical trials with the hope for an emergency use authorization in India later this summer. And in parallel, CEPI, the Coalition for Epidemic Preparedness Innovation, is working with Biological E for a global roadmap for phase 3 trials internationally. Just one other biographical piece. I do have a meaningful Canada connection. My grandfather, Morris Goldberg, grew up in the Jewish quarter of Paris and immigrated to Montreal around the time of World War I. And years later, he lost many family members during the Nazi occupation of Paris. So I always like to say that I only exist because of the goodness of the Canadian people who accepted my grandfather, and I've never forgotten that. Today, I hope to raise two issues, one in the area of COVID-19 vaccinations, the other on COVID-19 vaccines. So with regard to vaccinations, according to the New York Times tracker, as of yesterday, only 3.2% of Canada's population has been fully immunized, and just under 40% has received a single dose. In contrast, in the U.S., the numbers are 34% fully immunized and 46% a single dose. In the U.S., we also do have our problems, though. We have a troubling blue and red state divide, so that the real situation is that states such as Vermont, Massachusetts, and Connecticut will reach almost 1/2 of its population fully immunized, whereas the deep red states such as Idaho and Wyoming in the mountain area and our southern states are only about 1/4. And this disparity reflects an awful level of anti-vaccine aggression in our country. Unfortunately,
pardon me, doctor, if you could slow down a little bit for the interpreters.
Okay. Sorry about that. I'm also a bit of an expert in this anti-vaccine area because my youngest daughter, Rachel, has autism and intellectual disabilities, and I wrote a book previously called Vaccines Did Not Cause Rachel's Autism, which often makes me public enemy number one with the anti-vaccine group. Regarding Canada, I've publicly expressed my concern that our U.S. government could and should do more to help Canada vaccinate its population, especially given now with only 3% fully immunized. In my public appearances on the cable news networks and podcasts, including the CBC, I have explained why there are both practical reasons and emotional reasons for this. On the practical side, we share an enormous border. We simply cannot slow transmission by vaccinating all of Detroit, Michigan, for instance, without doing the same in Windsor, Ontario, or Buffalo, New York, without helping the other side of the Peace Bridge. On the emotional side, I've stated that there are not many nations who show the United States unconditional love, and I recount my remembrance in the days after the 9/11 attacks, when 100,000 Canadians stood on Parliament Hill in solidarity with the American people, and I point out there are not many nations who do such things. I've therefore stated when it comes to providing immunizations against COVID-19, there should be no daylight between the U.S. states and the Canadian provinces. In the area specifically of vaccines, I also believe that Canada has the potential to do more in vaccine science and production. You're a nation of some of the world's greatest research universities and medical schools. People come from all over the world to train at UBC, Toronto, McGill, Queen's, Waterloo, Western, Alberta, just to name some. Ultimately, it was the public agency of Canada's National Microbiology Laboratory that led the development of a successful Ebola vaccine that stabilized the situation in the Democratic Republic of the Congo. Our license to Biological E in India is not exclusive, and we'd be more than willing to transfer our technology to Canada so we could produce it for the world, if not for internal use. This might be part of a larger opportunity for the NML, the National Microbiology Laboratory, possibly in collaboration with one of Canada's research universities, to build a world-class center for vaccine science, development, and production. Doing so would propel Canada to the forefront of global vaccine diplomacy. So thank you again for this opportunity, and I look forward to having a discussion and dialogue and answering any questions you might have. Thank you again.
A little point of order, Mr. Speaker, Mr. Chair.
Yes, go ahead. Point of order.
Just, I think Mr. Pavelka actually had some further comments to go with the Slovak presentation. So if you wouldn't mind.
All right. Well, I absolutely. I apologize, Mr. Pavelka. I apologize. Please go ahead.
Dear Mr. Chairman, dear Vice Chairs, the honourable members of the Standing Committee on Health, dear friends in Canada, it's a great opportunity to present to you Slovak experience of the rapid antigen mass testing and how it can be effectively used to suppress COVID prevalence in population. In the next few minutes, what I want to do is convey three key messages, and that's present the Slovak experience, bust some myths about antigen tests, and mediate message on how to conduct effective, efficient, and impactful rapid antigen mass testing. From the Slovak experience, for us, PCR testing actually that was not the best test for COVID-19 epidemic for several reasons. The first one is the time lost to processing. By the time you get a time slot to go to a mass testing center, the laboratory processing time, all this time lost is just an opportunity for the virus to produce new generation lines. And secondly, the limited laboratory capacities meant that only symptomatic people were basically favored for the PCR test. On the other hand, with the antigen tests, you can scale them up. You can go to low cost. You can collect them at high frequencies, and you can actually cut more chains of transmissions. I'm just going to tell you some data or some basic data about our antigen test. So between January and April, through antigen testing, we detected almost twice as many infections as to the PCR channels. 250,000 infections were detected in this short time period. That's 5% of Slovakia's population. Half of these infections were completely asymptomatic at the time of testing. These people would have never been detected through standard syndromic PCR surveillance. One in 20 people were basically detected through antigen tests. So more or less everyone in Slovakia now knows someone from their close circle who was detected through antigen tests, and through timed isolation was able to basically prevent from infecting their parents, their friends, their loved ones. Slovakia conducted two main mass testing campaigns, one in November and then again from January or late January onwards. Now, every week, a Slovak resident is tested, and the test allows him to use exemptions from stay-at-home order. You can go to work, you could go to post office, bank, and so on. The methodology was basically laid by Michael Mina, Daniel Larimore. I call them the fathers of rapid antigen testing. Slovakia was one of the very first countries to actually conduct it. So I call Slovakia the poster child of the antigen mass testing. In our data set, the specificity of the test is actually really massive. From the low test prevalence in our counties, in our 79 counties, we could calculate that the specificity of the antigen tests used in our country is no less than 99.96%. From the 30 million antigen tests conducted during this period, 12,000 or no more than 12,000 were false positive. So really, when it comes to specificity, the false positive tests are not of a concern. When it comes to sensitivity, the tests are actually in Slovakia have proven to very well detect infectious individuals. And as I said, with the PCR test, by the time you actually confirmed you are infectious, you may not be infectious anymore. With the antigen tests, we are detecting only the infectious people. And the very final points to the sort of three key messages or three key ingredients from our own experience. What makes rapid antigen mass testing campaigns successful? First of all, is the volume. Other countries have tried it. In Austria, Vienna, for example, tried it. It didn't work. Only 5% of the population of Vienna turned out. That's not enough to cut enough transmission chains so you can flip the reproduction number below 1. Regularly, a third of the population gets tested every week. This seems to be working. Secondly, communication. One of the misconceptions about sensitivity is People don't trust the antigen test because of the lower sensitivity. Now, the point of rapid antigen mass testing is not to accurately detect infectious status of every resident. That's not the point. It's not a clinical test. The point is to detect enough chains of transmissions, and by cutting them, you are flipping the reproduction number below 1, and that's all you need. Once you achieve that, the epidemic will be decelerating. Communication is very important. The rapid antigen mass testing campaign only works when you communicate the messages very clearly with your population. And finally, the most important ingredient. From our data set, we learned that it's not enough to isolate the positive case, but you need to isolate the whole household. That's because of the secondary attack rate of the virus. Once it gets into the household, the member of the family will effectively infect the rest of the household members. So you need to isolate the whole household. And thank you very much. And I'm ready to take questions.
Thank you, Mr. Pavelka. So we will go now to our questions. We'll start with Ms. Rempel-Garner. Please go ahead, Ms. Rempel-Garner, 6 minutes, please.
Thank you, Chair. I'll briefly start with Dr. Hotez. I just wanted to thank you for your work in vaccine advocacy and dispelling myths around the vaccine link with autism. I think it's really important, and I just want to thank you for doing that. But I am going to direct most of my questions to representatives from Slovakia. You actually have the benefit of 3 members of this committee who have been to Slovakia. And I think that the national story of rapid testing is one that really should be celebrated internationally. I think it probably saved a lot of lives, and it's one that I think in Canada we're very interested in, particularly as we wait for vaccine shipments to arrive in Canada. So I guess, Mr. Pavelka, I'll start with you. I read your study called The Impact of Population-Wide Rapid Antigen Testing on SARS-CoV-2 Prevalence in Slovakia, which found that multiple rounds of population-wide rapid antigen testing decreased COVID-19 prevalence by 58% within 1 week. Can you explain and elaborate perhaps on how that rapid testing was able to achieve this?
Yes, there is a slight difference between the November campaign and then the current mass testing we're having now. And the one key difference is back then we didn't have the B117 strain. Now, almost 100% of our positive samples are B117, which is more transmissible. So we are not actually achieving 58% suppression of prevalence between each rounds as we did in November. We're still dealing with the old variant, but it's still measurable. We have the same vaccine coverage as all the other members of the European Union, yet we have one of the lowest infection rates. We're one of the first countries to actually get to almost the bottom very rapidly. What is the key success behind it is, as I said, isolating households. Because by isolating the household, you're actually effectively cutting the chains of transmission. So especially with the B117 strain, what we found is when a member of the family gets sick, the whole family now eventually develops symptoms. Whereas with the old Wuhan type or the pre-existing variants, the secondary attack rate was around 20-30%. Now literally the whole household gets sick. So by isolating just the positive case, you will not cut the transmission effectively. By isolating the household.
And I'm sorry to cut you off. My time is brief. I think the other thing that is really interesting about the work that came out of Slovakia is showing the amount and the prevalence of asymptomatic cases, which likely had a significant cause of spread in many parts of the world. I think in countries like Canada, where we have had stay-at-home measures, and certainly in the early start of the pandemic, there may have been asymptomatic spread, but it wasn't necessarily detected. I think then that there's this thought in the population, well, everything is fine, right? Do you think that there was a bit of a positive sociological impact as well on rapid testing, that like when you tested the whole population and you were able to show that there was spread and this was something that the country needed to take seriously? Do you think that perhaps helped compliance with the stay-at-home measures and then subsequently with a desire for vaccination?
This was the case in the November campaign because back then And we didn't test over a period of a week, but we did one round in one single weekend and then repeat again. And in those 2 weekends, we detected around 50,000, 52,000 infections. This was taken by massive surprise. No one expected that. And I think that's when it hit everyone. It is everywhere. And anyone can be a carrier.
And the other thing I would note is that I just think testing is so important. I think there's, you talked about myth busting. You know, I've heard many times that, you know, well, PCR tests are the gold standard, that antigen tests are less accurate. But what your experience has shown is that the volume, testing everybody regularly, helps to stop the spread of COVID, because you're catching many more cases than you would by just PCR testing symptomatic persons.
Absolutely, exactly as you said. It's a kind of an old Soviet sledgehammer method, I agree. But come on, how many PCR tests have we had? Maybe we in the government have them more often because we are exposed to many international meetings. But the ordinary citizen may have 1 or 2 PCR tests in a year. With the antigen test, you can ascertain your infectious status every week, twice a week. And this is the problem with SARS-CoV-2, because there's a large portion of the population that's fully asymptomatic. These people would never know that they are infectious. By taking the antigen test once, twice a week, I can ascertain my infectious status. I can find out, am I positive or not? And if I'm positive, I can isolate myself much, much earlier to prevent new generations or propagation lines of the virus. And if I'm negative, yes, then I can go to work. Then I can send my children to school.
Well, just with the few remaining seconds I have left, I do want to congratulate Slovakia on this excellent work. And certainly I look forward to, once fully vaccinated and once travel is safe, to visiting your beautiful country and seeing friends and family there again. So congratulations. And I think there's a lot of best practice we can take as a country from your efforts in rapid testing.
Thank you. Thank you very much. I have to confess, I love Canada, and I have many friends in Toronto, Edmonton, and Vancouver, and I traveled a lot to Canada in the past. So I hope that once COVID is over, I'll be back in Canada again.
Thank you.
Thank you, Ms. Rempel-Garner. And from Vancouver, thank you, Mr. Pavelka. We go now to Dr. Pawlowski. Dr. Pawlowski, please go ahead. 6 minutes.
Dr. Hotez, I spoke to you almost a year ago on convalescent serums. I don't know if you remember, but I didn't know then that you were one of the authors of the Bible. I've worked a lot of years in tropical countries, and before I go, I always buy the most up-to-date Manson's Tropical Medicine. So I'm really impressed. So now convalescent serum, I think, has been largely replaced by monoclonal antibodies. My understanding in the United States, the National Institute of Health now strongly recommends that they be used by high-risk people early on in the disease. And in the United States, if you get sick and you're high risk, you go to a website and the government directs you on to where to go for your treatment. Now in Canada, basically, we don't use monoclonals. So one, I want to get your opinion on that. Number two, your government nicely surprised me anyhow with the Biden announcement that it would back the WTO waiver on intellectual property rights related to COVID. What is your response to that? Do you think it'll work? And if you can answer quickly enough, I'd like to also get Dr. Bogash's response to both those questions. Thanks.
Yeah, I mean, I think the patent waiver could be useful. I have an article that just came out in Foreign Affairs this morning that basically says, the patent waivers are a good development, but insufficient to solve the problem, because the problem with vaccines are more complicated than small molecule drugs. So, for instance, if you have the structure of an antiretroviral drug for HIV/AIDS, the likelihood is you can bring together organic chemists and formulation experts and produce that drug, and the only thing standing in the way is the patent. With vaccines, they're far more complicated. It takes years to know how to create, build vaccines, and do it under a quality umbrella for quality control and quality assurance, and they're having the regulatory authority in place. So just by waiving patents, it will not be sufficient to solve this problem. What we need is the help from the U.S. government to actually make lots of vaccine for the world. I mean, look at the scale that we're talking about. There's 1.1 billion people in sub-Saharan Africa, 650 million people in Latin America. You've got about 500 million people in the smaller low-income countries of Asia. When you add up those numbers times 2 doses, we're talking about 5 to 6 billion doses of vaccine. And where's that going to come from? I mean, the mRNA technology is still new. It's a great technology. I got the Pfizer BioNTech vaccine, and I'm grateful for it. But can we scale that up? And what will a patent waiver do for that? Same with the adenovirus vectored vaccines. And we have our vaccine. So, for instance, our vaccine, we have a biological ease making 1 billion doses. Who's going to make the other 4 to 5 billion doses? So I think there's not an adequate foreign policy for producing vaccine at the scale that we need and in the time frame that we need. And we really need it now. We have the added problem, of course, that the whole game plan for the global vaccinations relied heavily on India to be the big producer between Serum Institute and Biological excuse me. And now those vaccines are not being exported because they're being kept within India. So it's like a domino effect, and the whole thing is kind of falling apart. So I worry that there's not an adequate structure. I mean, the COVAX sharing facility was well thought out, but the vaccines simply aren't there right now. And the key message, I think, for the Biden administration is thanks for the patent waiver, good first step, but now what are you going to do?
Thank you, Doctor. I'm obliged at this point to notify the committee that the bells in the House are ringing. We require unanimous consent to continue. May I suggest to the committee that we carry on through the end of this this first round? Is there agreement to do that? Anybody who opposes, please signify. No, I'll take that as unanimous consent. So, Dr. Hotez, I believe your answer was over. I will, Dr. Pawlowski had asked Dr. Bogoch to step in on this.
Maybe first quickly, Dr. Hotez, about use of monoclonal antibodies and the fact that you use them widely in the States, we don't use them.
Yeah, I think, they both work by the same principle. The idea being that the convalescent serum provides virus neutralizing antibody. The monoclonal antibody works that same way. The advantage of the monoclonal antibody, of course, is it's better quality. There's better quality control, so you know exactly how much antibody you're providing. With the convalescent plasma, it could be enormous variability, and so that's why. And that's why you're getting very inconsistent results as well. So if you have very high titered levels of convalescent antibody, it could work quite well, but a lot of places don't adequately measure it. So there is all that variability. And of course, the problem with both of those products is you have to give it very early on in the course of the illness, where you're still interfering with virus replication. Remember, there's 2 components to COVID-19. There's the virus replicating phase, and then there's the host inflammatory response. And once you delay and allow that host inflammatory response to continue, it's clear that the monoclonal antibodies and the convalescent serum are not working very well. So you have to give it early on in the course. So it's certainly no substitute for vaccination. I don't quite understand why monoclonal antibodies are not more widely available. In the U.S. too, there's been a problem. For instance, when my daughter-in-law got COVID-19, she was living in Arizona. I wanted to get her monoclonal antibody, and the infectious disease attending at the medical center there, gave me a list of about 100 criteria why she couldn't get it. So they've made it so fussy and complicated and limited the criteria that, at least for the last few months, maybe it's gotten better now, it was almost impossible to actually get it used for anybody.
Ron,
you're on mute, Ron.
Okay. Thank you, Dr. Pawlowski. Nous allons maintenant.
We now go to Mr. Thériault. Mr. Thériault, go ahead, please. Thank you, Mr. Chair. I'd like to thank our witnesses from Slovakia for having shared their experience with us. And I'd like to continue in that vein. Dr. Bogac, you reacted during their testimony, during the testimony of our witnesses from Slovakia. So what do you think of the use of tests here in Canada? And why is there resistance? What is the main source of resistance to using rapid testing and compared to PCR testing? So why not integrate rapid testing? I'd like to hear your thoughts on that. Isn't there a lesson that can be learned here so we can improve our practices in detecting the virus here?
So thank you very much for that question. And I'd like to thank our friends and colleagues from Slovakia for discussing their tremendous innovation and work. I completely agree with this sentiment that you suggest, and with the sentiment brought up by Ms. Michelle Rempel-Gardner as well earlier, that these are excellent tests that have been underutilized in Canadian settings. We have access to them. We just haven't deployed them as broadly as we should have. I think there's some general confusion amongst many Canadians as to the difference between a diagnostic test and the difference between a screening test. The PCR tests are very good for diagnostics. If you get sick and you want to know if this person coming into the hospital or into the clinic has COVID-19, you'd use a PCR test. But we're talking about rapid testing to help keep workplaces safe. You know, it's, as the example was given earlier, I'd much rather use a rapid test and detect most of the people coming in who are positive for COVID-19 by using these rapid tests, rather than detect 0 people coming in by not using any rapid tests. Like, it's a kind of a no-brainer, and they have been underutilized. What's very interesting in Canada is the business community figured this out first. Okay, while many of us in the medical and scientific community were debating back and forth, the business community just quietly went ahead and started integrating rapid testing and created much safer work environments. And this was most impressive. Here in Ontario, John Ruffalo is a well-known local business leader and started pushing this forward, and we were applauding him from the sidelines. I completely agree. We can utilize these tests much more significantly, and there's room to do so, because quite frankly, this virus ain't going anywhere. It's going to be around for a while. Even with mass vaccine efforts in place, we still need to create safer workplaces, and point of care rapid testing, the way that was described by our Slovakian colleagues, is a very smart way to do this.
Thank you.
Donc, si je vous comprends bien.
So if I've understood you correctly, we'll probably be living with the virus indefinitely, and all of these measures, these health measures that are essential but restrictive, they have a major impact on mental health and everything else in the economy. So when we want to relax the measures and head out of lockdown, it would be very good to use these rapid tests.
Yes, I would agree completely. I mean, I've spoken publicly on this. I've published in the academic medical literature on this. And I think that, they are underutilized in Canadian settings. There's certainly a much greater role for expanding the use of these tests. They're good. Again, you have to use the right test in the right place, interpret it in the right manner. But of course, I think in general, they have been underutilized in Canada, and there is plenty of room for expansion.
Dr.
Hotez, I'd like to hear your perspective on intellectual property and vaccines. You spoke earlier about the COVAX experience. 53 million people have been vaccinated through COVAX out of 8 billion people who need to be vaccinated, so it's very few. What would be your opinion on that? And I'd also like to hear your perspective on what your vaccine could do, what could it contribute in this vaccine race? Because at the beginning we saw that science was open, everybody was collaborating, but a little while longer, people were protecting their turf, and countries were being protective of their vaccines. So I'd like to hear your perspective and what effect could your vaccine have?
Yeah, unfortunately, I missed the beginning of that question, and my French is just not good enough. If the English translator could maybe just briefly summarize the beginning part.
Sure. What he was asking was about intellectual property and vaccines and what your vaccine could contribute.
Well, one of the things that we do, and thank you for that question, is we actually did not file any patents for our vaccine. So it's free and open to anybody who wants to scale it up and produce it. And we do this for practical reasons because the filing of patents is so expensive, and our biggest concern is access. So we provide non-exclusive license for our vaccines for just a minimal licensing fee. And then you have the opportunity to scale it up and produce it. And we put everything in the public domain, meaning we publish every step of the way so that nobody can actually block us either. And it's worked very well for us for our global health vaccines for schistosomiasis and Chagas disease. And we've taken the same approach for COVID-19 vaccines. And again, intellectual property for us is not the biggest barrier. It's the fact that most countries just don't have the resources and trained human capital to scale it up. And that's why I say for waiving intellectual property around mRNA vaccines, do not expect all of a sudden you're going to see lots of mRNA vaccines around. There is an enormous learning curve that's required in order to produce it. What you would really need if you were serious about having other groups start making mRNA vaccines, you have to ask the Pfizer and Moderna people to who have the experience now in scaling this up to actually enter into plants and with organizations and help them learn how to produce this at large scale. And that's why I say the waiving the patents could be useful in the long run. It may even have some short-term use. But if I were to rank the top 5 priorities right now for vaccinating the world, I don't even know that waiving the patents would be on the top 5.
Merci, Monsieur Thériault.
Thank you, Mr. Thériault.
Mr. Davies. Mr. Davies, go ahead. 6 minutes, please.
Thank you. I want to make sure I'm pronouncing your name right. Is it Hotez or Hotez?
Hotez, yeah.
Hotez. Thanks, Dr.
Good, yeah.
Hotez. Dr. Hotez, I know that the U.S. federal government developed a national vaccination plan. I think it was last November is when I recall seeing it. Can you briefly describe to us what that national vaccination plan looked like and what role the U.S. federal government played in developing that plan?
Well, unfortunately, in the last administration, the vaccination plan was mostly around ensuring that there would be adequate supply of vaccine, and that was clearly important. But it became clear that when the new administration took over, the plan, the logistics was largely focused on making certain that the boxes of vaccine would be kept without temperature incursions and delivered via FedEx and UPS and all of those usual mechanisms. And it was good that happened, but there was really not an adequate plan to vaccinate the American people. So the initial plan relied heavily on pharmacy chains and some of the hospital systems. And I think they did the best they could. But, especially in some of the low-income neighborhoods across the U.S., they're pharmacy deserts, and there was no mechanism for vaccinating, especially in low-income neighborhoods or even in a lot of rural areas. So I think with the contribution there of the federal government was to put a new plan in place in order to scale up vaccinations very rapidly. And that evolved as well, because when the Biden administration took office, they said they were going to deliver 100 million immunizations in 100 days. And that made sense, I think, in January, until we realized the B117 variant from the United Kingdom was accelerating as fast as it was. And a number of us in the scientific community said, well, it's great you made that commitment, but it's not adequate. You're going to have to triple that. And that was, I think, one of the more impressive things about the administration in 2021 is how they regrouped in order to triple the rate of vaccination, and that's why we're doing so well. So there was that all hands on deck. We still have problems now because we
if
do
I could,
have
Dr.
this.
Ortiz, I have limited time. I have a few other questions I want to get to, if
Sure,
I could. You sort of anticipated where I was going. I know that early in his term, President Biden, he made a series of changes to the plan he inherited, and that included setting up federally managed mass vaccination sites and deploying armed forces personnel, I think even National Guardsmen, to assist with managing them. Can you describe the role the U.S. federal government played in actually delivering vaccinations?
Well, they always have to work with the states, but I think it was in the planning and coordination of helping to create the sites and helping with the use of military and National Guard, and making recommendations to the states in terms of opening up some of the big sports arenas, for instance, to do this in a high throughput way.
Now, you've already talked about the comparative numbers of full vaccinations and partial vaccinations between the U.S. and Canada. Roughly, I think your numbers are that something over 40% of Americans have been fully vaccinated versus somewhere around 3%. So it seems to me that the U.S. has gone for more of a full vaccination strategy. Can you briefly touch on how that has come to be and why that is?
And they've also provided quite a number of single doses. So the numbers overall in the U.S. are 46% single dose, 34% two doses. But in the high-performing states, it's more like 60 and 45%. And the reason you could do it was because of vaccine supply. There was enough vaccine available from the 2 mRNA vaccines and less so the J&J vaccines, but that was what made it possible, the procurement of vaccines at that scale.
Thank you. Now, in a recent interview with the Canadian Press, you noted that you had assumed that Canada had essentially been keeping pace with the U.S. in terms of getting our citizens vaccinated until you looked at the numbers. You were quoted as saying, "I was really astonished. Only about a third of the country has received a single dose, and essentially no one's gotten fully vaccinated." Do you attribute that solely to supply?
I think that's probably the biggest barrier, is not having an adequate amount of vaccine. The good news is I do see the numbers picking up for the single dose. It's now heading towards about 40% single dose, so that's better. But still, in terms of full vaccination, the numbers that I see are only about 3%, so that rounds off to 0. Mm-hmm. So I think what I would like, and this is why I made the recommendation for the Biden administration to help to a greater extent. If it looks as though vaccine supply will continue to be low for the next few months, let's help the provinces as much as we can, both for those pragmatic and emotional reasons that I mentioned earlier.
Thanks. Now, President Biden recently set a new goal for vaccinations in America, calling for 70% of the U.S. adult population to have at least one shot and 160 million Americans fully vaccinated by July 4th. In doing so, he announced his administration plans to implement initiatives to bring the vaccine to people who are less eager to get vaccinated. Can you provide this committee with an overview of what those initiatives might look like?
Yeah, there were two problems early on that we had noticed back in December, that there were two groups that were highly vaccine hesitant. One were Black and Brown communities, and then conservative groups. And there were 4 news polls from PBS NewsHour, from Monmouth University, Quinnipiac University, and Kaiser, showing that about 40 to 50% of Republicans said they would refuse vaccinations. So I started doing two things. One, I began going on radio podcasts and radio program that reached Black and Brown communities. And the numbers did start going, the hesitancy really started going down. And I was on one very interesting one with in one of the historic Black churches in Richmond, Virginia. A pediatrician from the church invited me together with the pastor, and I said to the pastor, I said, the numbers look like they're going down, and what do you attribute that to? And he said, well, part of it are docs like you reaching out, but also the clergy in Black churches really worked together to help make that happen. And I think he's right. I think that made a big difference. But now the problem is more access in low income communities more than hesitancy. But with the conservative groups, it's still rip roaring problem. And you're seeing it reflect now in this disparity between blue and deep red states. So my fear is that we're going to reach some of those we will reach those benchmarks in the blue or bluish states and the Democratic strongholds, and that's already starting to happen. We're already reaching numbers that look like Israel numbers, but in the deep red states, we're still greatly underperforming and underachieving, and I worry about ongoing virus transmission there. So we have to do a better job reaching out to conservative groups, and I'm trying to go back on Newsmax and Fox News and stations like that to do what I can, but it's been really tough.
Thank you, Mr. Davies. So members, that pretty much brings our questions to a close here. I'd like to thank all the witnesses, particularly our visitors from the Slovak Republic, for their presence here, and thank you once again to Ambassador Kozak for his attendance. I would also like to extend my appreciation on behalf of the committee to all of the House of Commons staff, who, particularly today, we've had guests from all over the world, sort of thing, and it's quite difficult sometimes to wade through the technical issues. And so thank you really for that. And as well to the interpreters, often it's a challenging job at the best of times, but in times like this, it's even more so. So thank you to everyone. Thank you all. And with that, we are now adjourned.